I wanted to say that, yes, I do listen to RTE in the mornings because it makes me feel like I'm back here. But yeah, I really wanted to say thank you again for having me back over here to Ireland. And one of the thing I want to talk about, because this was from a first responder's point of view, is what do you do when you see penetrating injuries that come into where you're taking care of them in the field or into your emergency department initially? And there's some new things that have been developed, but it's still the basic injuries, but how do you handle them is what I wanted to cover today. So this is not what we're going to talk about today. That's a penetrating injury, not of the torso, in case you didn't figure that out. But this is find a Marine who was in the wrong place at the right time. Kind of a cool story. There he was, minding his own business, walking along a forward operating base when a rocket came in, blew up, took a tent stake and put it right in his head, and he walked right into our tent and said, "Hey, could you get this out of me?" Literally walked into our tent and said that. So he was okay and kind of half smiling until he touched that tent stake. Then he didn't like that too much. But anyways, it's not what we're going to talk about today. So in any approach to penetrating injuries, you have to know your anatomy. Anatomy is key. Thoracoabdominal injuries, that's one of the big things is this transition zone here. If you have any kind of penetrating injury at all, you're looking at a lot of different injuries you have to be cognizant of. If you're taking care of them in the field, you have to watch every aspect of them because they can decompensate in front of you very quickly. The flank and the back also, if you just think about it, and I'll show another slide with some anatomical different organs that are underneath the skin. Every one of those organs are critical. If they take an injury, it can be really bad news for you quickly. So you have to know your anatomy. You have to have a high index of suspicion. You have to be looking at these patients consistently. And remember, triage is dynamic. It's not static. I'll go over this again tomorrow. It is dynamic, meaning you have to continuously reassess these patients. I can tell you time and time again, I had patients come in off of a helicopter and they were dead. And all the medics, when they brought them off, so they were fine when we had them on the helicopter. They failed to reassess their patients. You have to do that. Until you deliver them into our hands, into the receiving area, keep doing that. The other thing with penetrating injuries in that same zone is diaphragm movement. As it goes up and down, it can allow things to penetrate into the thoracic cavity. That's what I was alluding to just a few minutes ago. So that could make a whole different scenario. You may think they have just a penetrating wound in the abdomen, and then all of a sudden they start having respiratory difficulties. Then you have to start thinking it crossed that border, and that could be very bad. Not to mention the fact there's a multitude of vessels that are in there as well, and those vessels are huge. Your aortas, your different thoracic vessels, if they get perforated, again, you're going to lose a lot of blood really quickly. So keep in mind, you're always thinking about abdominal injuries, cardiac injuries, and thoracic injuries when anything is penetrating these areas. So let's go over some of the anatomy. Any injury in this zone, I've seen shrapnel. I'll show some pictures of other types of penetrating injuries. Gunshot wound in this particular case, a transthoracic gunshot wound. Look at all the different things that it can cross and all the things that are really going to be bad. Now, the biggest thing is, from a first responder, what do I do besides go, oh my gosh, and get them on the bird? There are some things you can do with them, and that is, put them on oxygen. Be sure you watch all of their vital signs and get them to us as quickly as possible. There isn't a whole lot you can do for these patients in the field. When they get to a good colleague like my friend here, Dr. Barnes, he'll do the definitive work. He'll then put a chest tube in. He'll try to drain this fluid off their chest. But the thing is when you see them in the field and you monitor them and you re-triage them, he and I both need that information to know where they were and what they were back then when you picked them up and where they are now. That's the one thing we don't do very well in every facet of emergency medicine and also in combat trauma. We don't capture that information. That information is key. We're getting better at it. We're getting better monitoring systems as well. Once we get that information, it can help us know where they are on their trend, because they can look really well and then box, just fall off and die right in front of you. Your information, what you gather, and what you bring to the table when you drop them off is very important to us. So again, in that cardiac box, here, if you saw a patient that had a penetrating injury, look, it's right above the in the thoracoabdominal region, and right along the thoracic border. You would think, oh, that's also, but in this case, oh, it's got to be in the lungs. Well, not necessarily. There's also, in this particular scenario, there's a spleen, the stomach, everything else is right there. And depending on when they're breathing and how big the diaphragm came out, you could also perforate those organs as well. So always be thinking about that. So the things that you can do, these are the things as first responders you're going to do for these patients. You're not going to do this. That's for Dr. Barnes. He's a trauma surgeon and a darn good one. He's going to crack the chest. But what you can take care of, these are things where you can have preventable death, is how to treat a tension pneumothorax, how to do a needle decompression in a tension pneumothorax, and then how to treat sucking chest wounds. This is where you will save a life. So, what is a pneumothorax? Let's go back to basic anatomy and how we handle these things. All a pneumothorax is a collection of air that is in a place where it's not supposed to be. There's a potential space between the lung and the chest wall in the pleural space, and if that's violated in any way, then the lung will collapse. And when that happens, you've got a lot of problems because now they can't breathe, they can't get air into that lung. Now in a tension pneumothorax, this is a much worse situation. Now you've got air, the injured lung tissue acts as a one-way valve, and it traps air, pushing more and more air in there, and then squeezing the chest, pushing it over, the tracheal deviation, all those other things that you hear about. That is the last thing you'll say. Everybody says, well, when you have a tension pneumothorax, the trachea deviates. It's pretty much over at that point. You want to catch them before that. They get tachypnic, they can't breathe, can't get any air in, and you know that there's a problem. That's when this space gets full of air and it starts to compromise blood flow back to the heart. So pressure builds up and compresses both lungs and the heart. So what do? It's preventable death. I can't emphasize this enough. When I see casualties or I see patients coming into the emergency department and they're in this situation, it's tough because I can see everybody's all excited and trying to get him in there, but they never went back and reassessed the patient. If they had, they would have seen that they would have been having a harder time breathing. So tension pneumothorax, it can occur with entry into the abdomen, the shoulder, or the neck as well. Keep that in mind. Remember, all these zone injuries up in this area too are all connected. So that big box, that cardiac box that I was showing you, there's a multitude of injuries that can happen. So keep this on your high index of suspicion. So maybe cause also from blunt trauma too. Again, automobile accident, throwing against the steering wheel, it can cause it, and other things too, like obviously gunshot wound, other penetrating trauma, where you may think that the outlet is going to flow all the time. Maybe not so, it'll form that one-way valve. So both your lung function and your heart function, both impaired in a tension pneumothorax. They go into respiratory distress and they go into shock. The shock part is from not getting enough blood back to the heart from the pressure that's built up. So what do? You get progressive respiratory distress, then the treatment is to get that trapped air out of there. How do you do that in the field? Well, there you are. You have a patient, he's down on the ground. He or she, they can't breathe, and you know they've sustained a thorax injury of some sort. Now, what do? You can do a simple needle decompression. In our military services and most of our EMS services, they all have these 14 gauge, 3.25-inch needles with a catheter on it, which is basically just a very long, very large IV catheter. We put them on all of our kits to go into the field so that when with the medics or even the buddy aid care or advanced combat lifesaver care, we call it in our military, they were able to see this and put it in. We'd rather have them put it in if they thought it was going on than not, because it is preventable death. Now, because they did that, there was a lot of them that were placed in the wrong place and also for the wrong indication, so we went back to the drawing board and started more effective training on that. But what it does is you put it in the second intercostal space, in the midclavicular line, and you just push it down into that potential space to release that air. Once it's in there, the catheter can start to vent the air. And then that's what you want to do. Now, the problem with the catheters, they bend, and not everybody has the same anatomy. A lot of our people in the military are rather robust, muscular or otherwise. And that being said, the catheters were either not long enough, or they were put in the wrong space, so they were bending, and they end up having the same problem occur over and over again. So what we saw is that, especially in the military, because it was done so often, we were seeing multiple catheters being used on one patient. tried to come up with a better way of how we're going to do that. So what they did is, we had the Armed Forces of Pathology in our United States military, we got together and we looked at all the data, the postmortem data on these patients, and then looked at the pictures where they're placed, because when a casualty passes in the field, they leave everything in them, and they bring them back to Dover Air Force Base. They do CTs and all kinds of other studies on them to determine, what happened, and they want to also see where is the good placement for their interosseous needles, which is another talk for another day, and then these needle decompression needles. And what they found is they were misplaced a high percentage of the time, and were not that effective, if at all. So they went back to the chalkboard and they said, hey, listen, what are we going to do? They went to this newer protocol that's just come out recently. It's being implemented in the military, going on the side in the mid-axillary line, the 4th, 5th intercostal space. Better success, at least in training, and the chances of them misplacing it is less, plus tissue variability is less there overall. It's a thinner space. So that's what we're looking into the military, moving into that now also across all the training venues. The other thing that we did is there's a Very's needle. Now, Very's needle is used by surgeons when they do laparoscopies. They use it for insufflation into the abdomen, and basically it's a needle that has a bunch of inner spring. I'll show you a little sample of it up here when we get done. I have a picture in just a second. But a good trauma surgeon buddy of ours, both Steve and I, his name's Dr. Peter Reed. He was a combat trauma surgeon in the Navy, captain, he retired, and now he's the head of trauma at Tucson in University of Arizona. He operated on one of our congresswomen, Gabby Giffords, when she was shot in the head, and Pete took very good care of her. He's a very good trauma surgeon. He and I both think along the same lines. What if we use a Very's needle versus a simple catheter which flops over once the needle comes out of it? He did this, published this in our Journal of Trauma. Very busy slide to say one thing, is that when they used the Very's needle, they had a very, very high success rate, and that it was a much better avenue for treating these injuries than using the standard catheter that they had. So here's a good picture for you. This is just where you would put it in the second intercostal space, mid-clavicular line. And what you do is you insert the needle in there, and of course it relieves the pressure. Now this is what our standard needle looks like. Comes in our kits with this. There's the needle, there's the catheter. You can see, even though it's 14 gauge, you put it through the chest wall here, you have a high percentage chance of it failing. And I saw it over and over again. I know it works, and when it works, the number one way it works is when you hold it there with the needle in the sheath, and you hear the air venting out, that sucking sound. But as soon as you take it out, invariably that catheter can bend. Imagine transporting casualties, you're getting on a helicopter or an ambulance. It's nothing for this thing to bend over and fail. So what Dr. Reed did is he took this is what a Very's needle looks like. Look, it's a standard needle, and what you basically can't appreciate here about passing one around is that the needle, when you go to push on it, comes down over this cannulated sheath, so that the cutting edge of the needle goes through the tissue. And then as soon as it gets into the thoracic cavity, this ventilated needle pops through. So now the needle is retracted, it doesn't cut anything further, which was another thing we saw in a lot of the studies, is the tissue is damaged from those needles going in and out like that. And then you can constantly vent it. Here it has a stopcock on it to allow you to vent and go back and forth. One of the things that, it's a disclaimer, I actually invented this needle. I'll show you where it has an automatic pop-off valve on it. And so that you put it in, you leave it, and it'll vent itself, which is nice. So this is what we're looking at. And then the other, I didn't have a schematic for the other one, but again, it makes sense in the mid-axillary line where they replace these. So it takes the hole in the chest, a size of a nickel or bigger, to cause a sucking chest wound. That's my segue to sucking chest wounds. How many here have actually ever taken care of a sucking chest wound in their career? A few people. Yeah, I've had the fortunate or unfortunate experience of seeing many of them. Combat trauma, as I alluded to last year, is very, very nasty, ugly business with a lot of different moving parts. And Steve can contribute to this, or can also speak to this as well, from his tours overseas. And the thing is you see so much different injuries that you can actually miss something of all these different types of injuries. This is one you won't miss, is what I'm trying to say. When you see a sucking chest wound, you'll know exactly what it is. It makes a definitive sound, the distinctive sound of air sucking in and out of that open hole in the chest. Shrapnel is a good one for that, of course, gunshot wounds and so forth. But it only takes the size of a nickel and that open aperture in that chest, and you're going to have air going in and out, in and out. Obviously, this isn't good because it doesn't allow your lungs to the chest cavity depends on negative pressure, meaning this whole thing being sealed off so it can open and close. If air is going in and out, this will never be able to expand appropriately. So sucking chest wound, open pneumothorax, can result from large defects in the chest wall, and it definitely interferes with ventilation. What you do is you apply inclusive dressing over that hole, something that's going to seal it off. And you do that during, what you want to do is do it during expiration, and then it secure it to the chest so that the air won't keep going in and out. You monitor the unfortunate thing is that they end up having a subsequent tension pneumothorax. So a lot of patients be in the sitting position as possible, whichever one is more comfortable, but they're not going to be comfortable at all if they have a hole in their chest, but try to keep them as comfortable as possible. So what can you do? There's all kinds of commercially available things. You can, as a first responder, you can put these occlusive seals on them. I don't have any alliance to either one, but they go right over it, seal it off, and then it allows allows the patient to get more air back in there and have the lungs expand. So it should be treated with this dressing immediately, and you can use anything actually, a paper, plastic bag, or some backing off of. Use whatever you have at your disposal that's going to be able to seal that up, saran wrap or plastic wrap. But you apply it to the material, to the defect, and you just keep monitoring it because the chances of them having a tension pneumothorax are definitely high. So it's not over once you seal these wounds off. So sucking chest wound, here's another schematic for you. If you see any signs of a tension pneumothorax start to happen, that's why I covered that first, you want to remove it right away and let the air equalize. So you have an automatic treatment for a tension pneumothorax. Just take the plastic, occlusive dressing off right away. Now, penetrating abdominal wounds. Now, this would obviously be a bad day. This one too. But what do you do for penetrating abdominal wounds when you're a first responder on scene? Not a whole lot you can do. But the one thing you do need to understand is what not to do. So again, going back to that anatomy, this is the anatomy slide. You can see any one of these areas, there's different things that can happen that are all bad. From down here in the bladder to the spleen, kidneys, and then of course the liver. And the liver can bleed extensively. But even a perforated discus, intestines, small or large, you're looking at the possibility of developing peritonitis and also long-term sequelae. But in the upfront, these are patients you really got to watch quickly because they can decompensate on you. So abdominal penetrating trauma. The mechanism of wounding and the organ damage, again, you want to be thinking this poor unfortunate gentleman has multiple wounds, multiple problems going on. They come from stab wounds, knife wounds, gunshot wounds, but this is one of the ones where it really, I think when you have explosive injuries, I know when you have patients that are from explosive injuries, you really have to heighten your assessment skills because if you're not on them all the time, they could expire right in front of you, and when you thought they were doing quite well. So small and large intestine are often injured because they're the ones that are right up front with the omentum, which is a fat pad up the top of it with a lot of vessels in it. You can get lacerations, your solid organs, vascular injuries. The trajectory of the injury also gives you an idea where it's gone or what it's gone through. If they're hemodynamically unstable, you knew they automatically can assume you hit one of those large vessels in the abdomen. So what do you do for these patients? Well, again, this is a first responder lecture. When you see this immediately, the shock and awe goes, oh my gosh, what can I do for this? There are some things you can do. It's amazing the mechanisms of how these things happen. This was actually one of our casualties. But it's not what you think. What would cause such a bad injury like this? In reality, what it was, for me, I couldn't believe it when the guys finally told me what happened. This gentleman had a 50 caliber machine gun round go right past his abdomen. and it was the vortex from all the pressure going right by it. It tore up the skin on one side and caused an evisceration on the other side. It was amazing. But what do we do for this? Exactly what I'm going to tell you you need to do before they get in to see us. You want to cover it with a moisture gauze or a trauma dressing or an outer occlusive type of cover. A clean plastic bag. You want to put those bottles in the bag. You do not want to put them back in. Do not attempt to put all the viscera back into the abdomen. That is bad. Let the surgeons take care of that when they get to where they're supposed to be. You want to identify and try to control whatever hemorrhage you can and get them to the hospital as soon as possible. But main thing is try to support them. Don't let the intestines flop all over. Try to support them. Try to keep them together. There are some commercially available bowel bags, for lack of a better term, that are out there right now. There's a couple companies in the U.S. that are making them so for forward forces in the military for these kind of injuries, because sometimes transport can be many, many hours away. So impaled objects, what do you do with them? Nothing. Leave them alone. Don't mess with them. Do not pull them out. Try to support them in place. But just try to support them so whenever you're transporting it, it doesn't cause any more damage. You can see here, you have a rocker arm effect if you don't support it, and now you're basically dicing whatever's in there as you're trying to get to the hospital. So those are just the basic things that I want to cover, because a lot of times these injuries, they're going to need more definitive care. They're going to need the trauma surgeon, they're going to need our care up front. But I just want to understand that your job is critically important. Number one, you're there to stop anything that's going to cause a life threat. Obviously, bleeding, as well, Adrian was talking about. But number two, these preventable causes of death, these are the things that you don't really train a lot to, but you have to have a high index of suspicion so you can do what you need to do. And then the third thing, which Dr. Barnes and I can appreciate, is the information. We need that information from you, where the patient was when you saw them initially, and where they are when we bring them into the emergency department, because that way we get a good sense of where they are along their trauma timeline and how we can help them out as well. Any questions at all?